learning seminar series on the topic Respiratory Manifestation and Management of Pediatric HIV. Today's speaker is Dr. Subhasish Bhattacharyya, who serves as Professor of Pediatric Medicine, Medical College, Kolkata, and Program Director, Pediatric COE MCH, Kolkata. He is a National Master Trainer of NACO for training in pediatric HIV/AIDS and ART. He is a member of Pediatric TRG NACO and also a member of SASIP. He is invited as guest speaker and panelist on HIV/AIDS, infectious disease and nutrition in various academic meetings, symposiums and scientific conferences. He has several publications in national and international journals and has presented many scientific papers at various national and international conferences on pediatric nutrition. He is one of the reviewers of Indian Journal of Pediatrics and Indian Pediatrics Journal of IAP for last 3 years. Thank you, sir. I now request Dr. Subhasish Bhattacharyya to take over the session.
Thank you everybody. Today I will be presenting the pulmonary manifestation of pediatric HIV. Actually, pulmonary manifestation, the commonest presentation usually you get in pediatric HIV clinic, even in the OPD. So, to describe pulmonary manifestation, you should know a little about what HIV on lung. It's a various form of lung involvement in HIV/AIDS, one of the commonest clinical manifestation in children, and these are the predominant causes of morbidity and mortality below years of age. Developing country, pulmonary manifestation of HIV are problem with the epidemic proportion. Clinical presentation is often confusing, and diagnosis of various lung conditions are extremely difficult. What is the pathophysiology of pulmonary manifestation in HIV? HIV infects pulmonary lymphocytes, which results decrease in CD4 cell in the lung. So lack of activation signal from the CD4 cell, that is T lymphocyte, impairs the defense by the lung macrophages. And there is also lack of gamma interferon production by the T lymphocyte, as the number of T lymphocytes impair ability of the HIV T cell to activate beta cell in lung. So all leads to local significant reduction of the local immunity in the lung in HIV infected children. So these are the radiological presentation. I will be discussing one by one. All these cases that the particular pediatric patient presented with this radiological manifestation in the OPD, and ultimately we diagnose this condition and treat it accordingly. So this is another presentation will be later on presented with this radiological manifestation. This is another one. This is another very serious form we will be discussing subsequently. To describe the first clinical manifestation is a pneumonia. Here discuss the PCP, pneumocystis carinii, that will be discussed. That is also pneumonia, but that is interstitial pneumonia with a specific organism, that's one fungus. There is an increased susceptibility of bacterial pneumonia in HIV positive children. Developing severe pneumonia is 3 times greater than in HIV uninfected children. There is a highest incidence of pneumonia 20 to 25 per 100 child year, which mostly occur in first 12 months of life. Bacterial pneumonia may be due to gram positive, gram negative, and there are viral causes of pneumonia, including respiratory syncytial virus, measles, varicella, and currently the epidemic going on, that is flu. Flu virus also causes viral pneumonia in HIV positive children. Sometimes it is very severe. Mixed infection with multiple bacterial, viral and bacterial may occur, because actually the virus following viral infection, there is a secondary bacterial infection which actually complicate the viral pneumonia in HIV positive children. Staph and Streptococcus and Staphylococcus are the most common gram-positive organism, and also Haemophilus influenzae also common. Klebsiella pseudomonas are the gram-negative organism in HIV infected children. Recurrent bacterial pneumonia suggests WHO stage 3 disease in pediatric HIV. Recurrent pneumonia should be investigated to exclude other causes of similar clinical presentation like tuberculosis, which is also very common, lymphocytic interstitial pneumonia, and fungal pneumonia. Pneumonia with a skin lesion, especially the bullous skin lesion, and chest X-ray finding, typical chest X-ray finding suggests the staphylococcal infection is a very serious form of pneumonia in HIV positive children, and in that case we treat with cloxacillin and vancomycin because many of the staph are maybe multi-resistant. This is a radiological picture of a pneumonia showing typical lower lobe consolidation in a child. So another case showing typical middle lobe consolidation in a child, HIV positive child. So another case showing upper lobe consolidation with a small cavity, thick wall, and one pneumatocyst, and this pneumatocyst may rupture at point of time and may lead to hydropneumothorax or pyoneumothorax or pneumothorax formation, or which is a important and greatest complication in such setting. Repeat pneumonia may occur, and there is the same lobe consolidation, and when it is associated green mutum underlying lung disease, the gram-negative organism may be associated in that case. In that case, we use aminoglycoside along with the third generation or other antibiotic or other antibiotic. Cotrimoxazole prophylaxis associated with decrease in morbidity and mortality in severe pneumonia. But there are some reports that even some organisms which actually resistant to this so in cotrimoxazole prophylaxis patient we may get those organisms which are resistant and may complicate the picture. Haemophilus influenzae and pneumococcal vaccination is beneficial because this is of one of the causes of pneumonia in HIV like other normal children. Vaccination is in this group of pneumonia, Haemophilus influenzae and pneumococcal. Now discussing about tuberculosis infected children. HIV pandemic lead to the resurgence of tuberculosis. Burden of TB in children depends on burden of the disease in adult population. There is an increased risk of developing progressive primary TB in presence of HIV. Extrapulmonary TB is also more often seen. Pulmonary TB is stage 3 disease as per WHO classification. Extrapulmonary TB is stage 4 disease clinical illness as per WHO. So this is extrapulmonary tuberculosis. Initial was pulmonary tuberculosis, and it was not properly treated or not properly diagnosed at the time. Consequently, this is a dissemination lead to this dreaded complication of tuberculosis, that is tubercular meningitis with lot of basal rate, and this pressure increased pressure leading to increased pressure leading to raised intracranial pressure in this situation with a dilatation of ventricles. So in all such cases, always look for the adult contract of a tuberculosis which is commonly present in such situation. HIV TB coexists in 20 to 48% of children. Extrapulmonary and miliary TB are more common in younger children, and sometimes there is a presence with atypical presentation. Mantoux test commonly done to diagnose TB is generally negative due to immune suppression. If positive in a asymptomatic child, latent infection should be considered and treatment may be required. Screen family member and test for the drug resistant in the source when there is no response with anti-tubercular medication in this group of children. What are the important clinical feature of tuberculosis infection in HIV positive children? There may be fever, usually more than 2 weeks. Cough may be there more than 2 weeks. There is a poor weight gain along with the weight loss, and pneumonia in such cases which is diagnosed is not with antibiotic, then there is a possibility, high suspicion should be there that tuberculosis may be associated infection, and the distant lymph node enlargement we may get in such cases. Higher case fatality rate in children who are co-infected with TB and HIV. It is important to look actively for TB in children with prolonged and chronic cough. This picture showing there's a mycobacterium is a smear, but this presentation is not always, it's not common, not so much common in presence of tuberculosis in children in HIV, because bacterial isolation is sometimes difficult. But lymph node tuberculosis, when it is diagnosed, and if we can take a smear from lymph node or biopsy from lymph node, there is a high chance of getting mycobacterium tuberculosis in such smear. Diagnosing tuberculosis is difficult in children, but it's more difficult in presence of HIV in children. There may be other condition, an HIV related condition, chronic lung condition that mimic tuberculosis, mimic symptom both radiologically and clinically in HIV. So those important condition must be considered, and tuberculosis must be excluded in that situation. Clinical suspicion and diagnosis of TB in children is difficult as compared to the adult, because in most children there is no signs and symptom. There may not be initially any radiological abnormality. Identification of bacillus is less reliable and very difficult in presence of in tuberculosis in HIV. And also children rarely able to produce sputum. So that is another very important thing, because like adult, we less than 6 months they can't expectorate. So very often they can't expectorate, and we cannot get any sputum for bacteriological confirmation of the diagnosis. Most TB diagnosis criteria like chronic symptom, smear positive contact, and positive Mantoux test response to treatment have a lower sensitivity and specificity in co-infected children than in non-infected children. Yes, there is a role of CVNAT. CVNAT is cartridge based nucleic acid test, can be done for gastric aspirate or older children who can expectorate sputum. We can go for CVNAT. Now it is available in many centers across India, in different center it is available. So you can go for CVNAT test from sputum or some other body fluids like CSF. We can go for CVNAT test. Usually TB diagnosis is done by Mantoux testing, which is more than 5 mm considered positive. Normally normal children, infected children, if Mantoux is more than 10 mm considered is the positive. Immunosuppression like HIV, if it is more than 5, it is positive test. Gastric lavage or induced sputum can be taken, and sent for CVNAT testing or bacterial isolation. X-ray test should be done, and radiometric bacterial culture and is often helpful, but it's expensive, available everywhere. Bronchoalveolar lavage can be done, and from bronchoalveolar lavage specimen CVNet or other isolated bacterial isolation technique. Tissue diagnosis wherever needed is possible, but serology and PCR are often not reliable, and we should not go for this PCR and serology routinely for diagnosing TB in HIV positive children. Regarding tubercular skin testing, only practical tool for diagnosis of latent infection in method usually 0.1 ml 5 ppd purified is injected with a 27 gauge needle and tuberculin syringe. TST, this skin testing is delayed type of high response. Read after 72 hours and in duration, not the erythema, very important point to note, and that too also in transverse diameter should be taken, recorded in millimeter, and not mentioned as a negative or positive. A trained healthcare professional should measure the tuberculin skin testing. And this is how we should measure the tuberculin skin testing. It is in transverse diameter, and only the induration should be taken, and it should be expressed in millimeter. Tuberculin skin testing may be false negative when the technique is poor, when injection was done too deep. There is a poor quality of tuberculin which is not potent. Child is associated with severe malnutrition and some viral infection. Following this viral infection like measles, varicella, or some live vaccination, after that if we do want to test, it may be negative. And nearly half of the cases of HIV associated with negative to testing. And in case of severe TB like miliary TB or meningitis, it may be negative up to 25% of cases. And in some, more than 5 millimeters taken as a positive in places of HIV. When HIV is present, and also in miliary TB, more than 5 millimeters taken as a positive, and any child HIV positive or HIV negative on immunosuppressive, more than 5 millimeters taken as a positive, and when there is associated malnutrition, also 5 millimeters is taken as a positive. But two interferon gamma release assay have been approved by the FDA for the use in USA in the place of TST. This is in vitro test, is similar like tuberculin skin testing, but it get measurement is in vitro, but it is expensive test, not routinely we can order for the diagnosis of TB in positive children. Particular child is HIV positive, showing following tubercular injection. This is a vesiculation and induration, but this kind of picture is very rare in presence of HIV. Many of the cases, this reaction, there may not be any induration with tubercular injection, this kind of vesiculation, and that too also in a HIV positive child. So this is a X-ray picture of a pediatric tuberculosis in HIV. What you are seeing here is a bilateral hilar adenopathy, very characteristic of pediatric tuberculosis in presence of. So another picture showing bilateral, this is a lymphadenopathy, the clear picture. So cases where we have observed the lymphadenopathy, hilar adenopathy, we should order the lateral chest X-ray, a lateral X-ray showing beautiful hilar adenopathy. So the pleural effusion in presence of with a TB infection, but It's not that in presence of HIV, because mostly found in where immune deficiency is much profound. Of these cases, so with a very low immunity shows of this relation. So, but from HIV positive a child and showing this pleural effusion, but this is not very much common in presence of tuberculosis in HIV positive state. This is another serious form of TB showing miliary mottling whole over the lung is a miliary mottle, and so this is known as miliary tuberculosis. But this miliary mottling, that is this disseminated tuberculosis, may to the CNS and lead to CNS tuberculosis in such case. Treatment usually on sometime on presumptive basis because etiological diagnosis is difficult. Treatment of similar like HIV uninfected children, the tuberculosis treatment is similar here also. Duration of continuation phase is prolonged here, total 7 months for pulmonary tuberculosis. Because of interaction between nevirapine and rifampicin in a child who are co-infected, treatment have to be modified. So this is applicable not only for nevirapine, now the protease inhibitor, loperamide also there's a modification is required, because both of these drugs are extensively metabolized by rifampicin, so the blood level decreases, so modification is required. Regarding viral pneumonia may develop in severe viral pneumonia from respiratory syncytial virus, influenza virus and parainfluenza virus, adenovirus, varicella virus, CMV virus and also measles virus in presence of HIV. In our setting, it is not always possible to confirm the actual etiological agent. Clinical presentation may be much more severe with a higher case fatality rate in such cases. We should consider viral pneumonia, particularly in epidemic setting, and we should treat accordingly in such cases where antibiotic only be the choice. So where it is available, some antiviral drug. Usual presentation is pneumonia rather than bronchiolitis, and this is a giant cell due to the measles, not uncommon in children more than 15 months of age. So there is a measles pneumonia or varicella pneumonia which may giant cell pneumonia, giant cell formation in the lungs, and known as giant cell pneumonia we may get in presence of HIV. Regarding fungal pneumonia, Pneumocystis cerevisiae, formerly known as Pneumocystis carinii, is a major cause of severe pneumonia up to 15 to 30% of cases, and death up to 30 to 50% in HIV infected infant. So very important cause of death in infant due to this Pneumocystis cerevisiae pneumonia. Infants are usually in a good nutritional state and may not have any other clinical feature that indicate HIV. So that is very difficult initially. Many of the pediatricians and physicians, they don't suspect it that this could be due to fungal pneumonia. Everybody actually treat this condition with antibacterial, where they say no role of antibacterial in Pneumocystis cerevisiae pneumonia. High degree of suspicion is required, especially when infant is below age. Incidence is highest in first 1 year and peak at 3 to 6 months of age. There is a diffuse disformative alveolitis, and alveoli become filled with foaming exudate and cyst containing sporozoite. There is a low grade fever which with a marked respiratory distress, and this differentiate with bacterial pneumonia. Most of the bacterial pneumonia in presence of HIV has with very high grade of fever, and respiratory distress is severe in case of PCP, and which maybe there is a cyanosis from the beginning in presence of Pneumocystis carinii pneumonia. The chest is usually clear, and sometimes we get fine crepitation in contrary to the other bacterial and viral pneumonia. And there is a severe persistent hypoxia, very characteristic. Usually the saturation may be below 90%. Induced sputum and nasopharyngeal and bronchoalveolar lavage may help to diagnose this condition. So this fungal in bronchoalveolar lavage from a child with a pneumocystis carinii pneumonia. And this is a typical clinical presentation at the beginning of PCP, and that is the reason many of the time PCP is misdiagnosed. But initially there may be mild infiltrate. And mild opacity in the parahilar region. But if this X-ray is repeated after some time, after 4 to 6 hours, what we'll see, the whole lung may be opacified, and this is the ground glass opacity of the lung, which may not occur at the beginning of the presentation. And in this picture, what we are seeing, this opacification has started from the parahilar region and extending to a periphery like this. So these are the important radiological manifestation of PCP. But one point to note, the initial X-ray may be normal, but subsequent X-ray we should consider in such cases, and then we can only see that opacification further. There is a bilateral diffuse parenchymal infiltrates, the ground glass appearance of the X-ray, extending from the perihilar to the peripheral to reach the apical portion of the lung. In some cases, there may not be any specific radiological changes of PCP, what I mentioned before at the beginning. So repeat X-ray may be required. Usually the total leukocyte count is a normal limit in case of PCP, in contrary to the bacterial pneumonia where leukocyte count is very high. So leukocyte count is normal in PCP, along with a very high serum lactic dehydration, usually more than 1000 international unit per liter we may get in PCP pneumonia in contrast to the bacterial pneumonia. Immediately oral or IV, but available is oral cotrimoxazole 20 mg per kg per day of trimethoprim in a divided doses, along with the severe cases IV or oral prednisolone 2 mg per kg divided doses should be given. And cotrimoxazole dramatically reduces the incidence, prophylaxis actually dramatically reduces the incidence of PCP pneumonia in HIV population. The other fungus like Cryptococcus, Histoplasma, Candida, Aspergillus and Penicillium rarely may be associated with severe pulmonary involvement, but not that much common in pediatric population. So there is another chronic condition where there is no infective etiology is there in presence LIP. Lymphatic interstitial pneumonia is a common in as high as 40% African HIV positive children usually suffer from LIP pneumonia, interstitial pneumonia. Usually in the adult, very important, common, not uncommon presentation in children with HIV. Occurs in children usually more than 2 years of age. There is a diffuse infiltration of the lymphocyte, plasma cell, histiocytes in the interstitium and scattered nodules with a mononuclear cell infiltration. If from the lung histology, biopsy and histology, you see lot of mononuclear cell infiltration and nodule formation in the lung. This is typical clinical picture presentation of a LIP, lymphocytic interstitial pneumonia. And many of the cases what I have seen is that they were running from here to there, from one pediatrician to another pediatrician, one physician to another physician. Many of them are actually presented with respiratory distress, and many of the time it was diagnosed as some kind of bronchospasm or asthma, LRTI, and many of the with bronchitis and sometimes steroid. Every time they comes with these, but in contrary to this other chronic lung condition like bronchial asthma, like respiratory condition, the characteristic feature of LIP is that presence of bilateral digital clubbing, and sometimes we may get even frank cyanosis. So cyanosis with digital clubbing, which is uncommon in pediatric population with any bronchial condition like bronchial asthma or chronic bronchitis, which is very uncommon, but LIP, the child LIP may present with this condition. if we get this group of patient, immediately we should consider HIV infection and we should rule out HIV and then do subsequent investigation and treatment also. And another very important point to note, I will come to that later on. The same patient with in a close-up view showing the bilateral digital clubbing and cyanosis. LIP is often mistaken for pulmonary tuberculosis, biliary. Yes, this is commonly. I have seen few of such LIP patients. They have received 2 or 3 times anti-tubercular therapy because X-ray picture was so confusing. Even experienced pediatrician thought that it could be due to tuberculosis infection. So it mimics tuberculosis infection if you consider radiologic only. So you have to examine whole patient properly and diagnose this condition. Have a good general condition in positive children and associated with tender parotid enlargement and generalized and hepatosplenomegaly is there, and already I mentioned the clubbing and cyanosis is mostly associated with this condition. This is a clinical picture, X-ray showing bilateral nodular appearance, reticulonodular appearance of parahilar region. There sometimes may be hilar gland in the apical part, and this nodule formation may be there in other part of the lung, and that actually confused with pulmonary tuberculosis or miliary tuberculosis or tuberculosis infection with a hilar adenopathy. So in such cases, definitely we should consider TB, and we should rule out TB in LIP, because we know the LIP management of LIP is not only the bronchodilator but also prednisolone, oral steroid that may disseminate TB. So ruling out of TB before initiation of LIP treatment is very important, and we should consider but rule it out. But this is a clinical picture of radiological picture of LIP which confuses it with tuberculosis infection. Even when there is no confusion, we should rule out tuberculosis in such cases before starting treatment. So it's a diffuse bilateral reticulonodular infiltrate with a bilateral hilar or a mediastinal lymph node enlargement, which actually confuse us with a with mediastinal enlargement. Tuberculosis excluded at the beginning, and then oral prednisolone 2 mg per kg per day in divided doses should be given for 4 weeks, then alternate day maintenance for 2 to 3 weeks, then we can taper it. Along with a bronchodilator, oxygen, chest physiotherapy and antibiotic may be needed. And when for CD4, if CD4 is low, according to, as we know, this LIP is a stage 3 condition, but if that required CD4 is low, we should start antiretroviral therapy along with this management of LIP. So other pulmonary condition may be associated are bronchiectasis is a complete pneumonia may be there, and radiologically may be present as a persistent abnormality in the same lobe for more than 6 months. Other pulmonary condition which may be there in presence of HIV is the Kaposi sarcoma, which is very uncommon in children. There is a multiple, in Kaposi sarcoma there is a multiple endobronchial hemorrhagic nodule, diagnosis only, and biopsy should be taken, but sometimes this biopsy is confined because there may be profuse hemorrhage. So biopsy only can be taken with a setup and with a lot of caution to be observed before taking biopsy. But treatment is by vincristine and bleomycin, anti-cancer drug. But prognosis is not good for Kaposi sarcoma in presence of HIV. So to conclude this presentation, lung involvement plays a major role in morbidity and mortality, and there are preventable conditions like PCP, tuberculosis, bacterial pneumonia. Bacterial pneumonia are common. Only high the index of suspicion and early and effective treatment along with a prophylaxis of ART can prevent morbidity and mortality in HIV positive children. We all know that prophylaxis, that is cotrimoxazole prophylaxis for PCP, should be offered to all newborn baby exposed to HIV, that is HIV exposed baby should be started immediately, and child should be offered PCP till 5 years of age, and even after 5 years it can continued for some time, because PCP not only prevent only the pneumocystis carini, cotrimoxazole not only prevent only, but it prevents host of other bacterial infection, including bacterial in HIV positive. And for vaccination, like already I mentioned, Haemophilus influenzae vaccination, pneumonia vaccination, though these are little expensive, but who can afford it, they will in the long run prevent lot of these bacterial dangerous pneumonia like Haemophilus influenzae and pneumococcal pneumonia in this group. Regarding one question, they have asked that how common the pulmonary cryptococcosis histoplasmosis in children. Actually, only cryptococcosis and histoplasmosis only we get with a very low CD4 count, but in pediatric population that very much low CD4 count is not usually we get, and many of the time, as now the antiretroviral we are starting at the beginning, so hardly ever the CD4 will drop so low in such cases. So in future also will be this cryptococcosis and histoplasmosis are will not that much common in presence of HIV, but definitely when there is any suspicion, we should consider in this case, especially when there is a cryptococcus nodule and other suggestive clinical presentation which suggests cryptococcosis or histoplasmosis, we should consider, diagnose and treat accordingly. Prophylaxis therapy in case of in HIV children who are exposed to open case of tuberculosis in the family, any family member suffering from open tuberculosis, in that cases the now recommendation is to initiate INH prophylaxis, which is 10 mg per kg and should be continued, not 3 months like before, should be continued for 6 months. This INH prophylaxis should be continued. Yes, HRCT can be done to diagnose this condition, but many of these pediatric common presentation, proper clinical history, radiological examination, investigation are helpful, but in some cases, yes, HRCT can be undertaken, but these are expensive tests, sometimes where it is not available, it is difficult to get. So definitely HRCT is helpful, especially for LIP with TB infection, PCP infection sometime, and also the complicated HRCT is helpful. A Mantoux test can be considered in all TB all pediatric cases up to 12 year, even more up to 15 year. We actually pediatric it up to 15 years per NACO guideline. Says with a suspicion we can to test to differentiate to diagnose tuberculosis. Yes, we should for Mantoux testing we should wait for at least 72 hours, and after 72 hours we'll take the transverse diameter of this induration, not the erythema, and then only can if it is more than 5 mm is taken as a positive, but less than 5 mm is not taken as a positive. More than 5 mm is taken as positive, but definitely not only the only Mantoux test, presentation and investigation, radiological presentation, radiological feature is also should be considered when you considering TB in presence of HIV. I mentioned morbidity and mortality in PCP is very high up to 20 to 30%. In some cases it is 40% mortality due to PCP, as PCP is most common in below 1 year of age. Mortality is very high, but LIP as per is not that much high mortality condition, but morbidity is more. In LIP there is a frequent suffering, severe respiratory distress every time child is admitted and given bronchodilator and steroid. So that is there, that is morbidity, but mortality wise LIP is not that much dangerous. Actually, BCG is usually indicated at the age of at immediate after birth, or at least by 15 days after after birth, that for the best result. But it can be given after some time. But in HIV positive situation, we should consider their immune status and we should know their CD4 before advising BCG, because BCG is a live vaccine with a severe immune depression. There is a chance that BCG may be disseminated, leading to local adenopathy in the axilla, or even BCG may extend even up to the lung, leading to VCG pneumonia in presence of HIV infection. So that to be considered. If child is old where BCG is not given before, we should rule out their we should see their immune status and go for CD4, and then only we will advise the BCG vaccination. Preferable nowadays recommendation is, if it is 1 TU or MANTU testing, so 1 TU should be with a twin 80. That make 1 TU equal to 5 TU. But twin 80 is a costly detergent usually added with tuberculin. It is not available everywhere. So for practical purpose, it should be 5 tuberculin unit rather than 1 TU. So 5 TU now recommended for MANTU testing, not 1 TU. CVNAT, one question was there, the age of CVNAT. Age of CVNAT, from any age you can start this CVNAT. A small baby, 3-4 months present suspecting tuberculosis, you can take gastric aspirate and send the aspirate for CVNAT testing. So no age is no bar for CVNAT testing, and CVNAT testing is usually applicable for sputum or any other body fluid except blood. Body fluid like pleural fluid, like CSF, CVNAT can be applied. One question was, co-trimaxal prophylaxis any helpful for LIP or not? No, there is no role of co-trimaxal prophylaxis in LIP, because LIP is a unique condition usually you get in HIV. That is, HIV hypothesis is that it is an interaction between EBV, that is Epstein-Barr virus, with HIV virus in the lung, and that results the LIP. And LIP is there is no co-trimaxal prophylaxis is not as, but co-trimaxal help in that way that this LIP patient may develop complication develop as a pneumonia. So co-trimaxal help in that prevention of the pneumonia or PCP infection, or not it will not prevent LIP in HIV. One question was vitamin A in the prevention of respiratory symptom. Yes, vitamin A is a very important micromolecule or nutrient which actually boosts up immunity in children and also adult. So vitamin A supplementation should be there as per national guideline, or any child which is showing vitamin A deficiency should be treated immediately, because vitamin A deficiency in presence of HIV, actually they are doubly immunocompromised. So chance of respiratory infection, not only respiratory infection but other infection include GI infection also increases. One question was that the child was taken anti-tubercular therapy for PTB for a period of 1 year. However, the symptom did not subside and was diagnosed on MDR TB and completed treatment. However, X-ray is still showing PTB. So probably that MDR TB was not responded well. So all such cases with MDR tuberculosis, and I have mentioned in my slide, then